So thank you for the introduction. And I'm going to talk instead of Dr. Kohn. And my major field of research is actually second-generation SCI, but I'm also extending the presentation to stem cells. That's something really close in the research today. So I wanted to acknowledge the first-generation SCI. Lars Peterson was supposed to be here. And actually, you have to say, after 20 years of research, the results, clinical results, are great, as well as imaging results and histological results. And yes, we had some controversial studies in the last years, like Knudsen showed that there is no difference with respect to repair procedures like microfractures. But some more recent studies showed that we can have better histological results at the short term with first-generation SCI. And these results lead to better clinical results over time. So having a better tissue can give us better results over time. It seems different techniques can give you the same results, but only at short-term follow-up. Anyway, despite we have such a good results with the first generation, after years of basic and clinical research, researchers developed many strategies, many different options to try to increase cartilage generation. And the most documented is the second generation SCI. That means the use of scaffold to seed and transplant a tissue inside the cartilage lesion site, not just cells. In particular, we have experience with one scaffold, is a hyaluronic acid-based scaffold, and Professor Marcacci developed an arthroscopic procedure. This is another advantage of using tissue engineering approaches. And we also performed a comparative study. It's not a randomized study, but okay, it's coming here. But it's still interesting because it shows comparing second-generation SCI and microfractures that we can have better results at 5 years with Yarograph-C. As you can see from the graphic, we have better results with Yarograph-C at 5 years. And interesting, you see there are same results from the activity level point of view of 2 years, but the better tissue that we can have with regenerative procedures give us durable results, whereas there is a worsening with microfractures. We also more recently performed another evaluation in a really demanding patient population, soccer players. So we wanted to see the different results with different approaches for this particular category of patients. And what we observed is that we had better results, faster return to sport with microfractures 4 months before the first official game. So actually the recovery was much faster, significantly faster with microfractures. But when we look at the results over time, this means at 5 years, results are much better for Yarograph-C than for microfracture again, and also the sport activity level. There is a decrease in microfracture, much more than with Yarograph-C. So what we can say, then microfracture guarantees a faster recovery time, but there is a worsening over time. So if we have to choose a strategy for these patients, we will suggest to use the regenerative approach because we can have long-lasting results. But for sure, in soccer players, there is also the space for microfracture because there are patients at the end of the career, they can't wait too long to go back to sport, or with contract problems. So there is some space for microfracture, even if we think we should always try to choose the regenerative approach. Anyway, we had these good results with the sport-active patients, but also we wanted to analyze how the results were for a more general population of patients. So this is our case series. 62 patients achieved 7 years of follow-up. And here are the results. As you can see, there is an improvement, significant, a high improvement at 12 months, a further slight improvement at 24, so there is still a maturation probably of the graft at 2 years. And then results are stable over time from the subjective point of view and also the sport activity level. Then we wanted to know if these results were influenced by different factors. So we asked ourselves, is this technique suitable for older patients? You see, there is a correlation between age and results we can get. And we performed a specific evaluation for patients over 40 years old in collaboration with the group of Verona. We analyzed patients treated by Yarograph-C and patients treated by the classic MACI. What we observed is that we can get to 70 points of IKDC. That's a good score. There is an improvement. It's not as high as for other patients. There is 20% of failure at this medium-term follow-up. That's not low, but there are not many options for these kind of patients. And interestingly, we have the same results at medium-term follow-up with the two procedures, but faster recovery with Yarograph C. And so I underline again, Yarograph C was applied arthroscopically, and the MESI was applied arthrotomically. So in the open procedure, this makes a difference for the recovery time. And last thing we observed is that in this particular category of patients, males have a better recovery. We also asked ourselves, are these results, these techniques suitable also for degenerative lesions? And it seems not. So we tried to go to analyze more in detail also degenerative lesions. So this is a study specifically with patients with microtraumatic degenerative lesions without clear signs of osteoarthritis, with a long duration of symptoms and lot of previous surgeries. And here are the results. There is an improvement, is significant, but lower, much lower than with other etiologies. And also the failures, again, among 20%. And really interesting, you see the failures are all in the degenerative group, not in the microtraumatic sport-active patients. So when is the sport, the microtraumatic, the overuse, we don't have so many failures. When we have the failures is when probably there is a tissue quality problem, when the cartilage is diseased. So in this case, we can expect really good results, and we have many more failures. And also the evaluation at MRI showed not exciting results. And in particular, you can see that subchondral bone changes is something that now we are really looking more in the detail in the new treatments we are developing, because it's a really important aspect to consider. And what regards to complex lesions, a significant decrease of clinical outcome over time and huge number of failures when we treat complex lesions. Again, maybe here there is a problem of the subchondral bone. And the analysis of the subchondral bone shows that with problems of the subchondral bone, we have the worst clinical outcome. The last aspect we study of the second generation SCI is the rehabilitation phase. That's a really important aspect because it requires so much time and has to be really well followed after the surgical treatment. So we wanted to know if we could improve the restoration of function through an intense rehabilitation, but at the same time we wanted to know if it was possible to optimize the achievement of the goals, forcing the rehabilitation, but without jeopardizing the results. What we observed is that with an intense rehabilitation, we have good results at the beginning. We expected this, but we didn't jeopardize the results. We even have, on the contrary, better results at medium-term follow-up. So actually, rehabilitation is an important phase, and if it is done properly, we say function step-based, not time step-based, so we have to wait that every step is achieved before passing to the others. But if we do it properly, rehabilitation can really help to achieve better results at the beginning and also to maintain results over time. I talked about second generation SCI, and as for the first generation, is a two-step procedures, but now the trend is to go to one-step procedures through the use of biomaterials for in situ regeneration or to be augmented, biologically augmented with different products, PRP, mesenchymal stem cells, bone marrow concentrate. So this is the new trend. We try to use smart biomaterials for one-step technique to induce the regeneration with or without stem cells, PRP, etc. The contra summarizing are actually that we don't know how they work. It's everything new, so we don't know what to expect. The pro are many. It's easier surgical technique, less time, less cost, so there are theoretically pros. And there are many, many studies now ongoing on chondral and osteochondral scaffold. Most of them are still at the level of animal studies. Some are at the level of the pilot clinical studies, and a few products are already in the clinical practice. Here, just a few examples. I'm going to really fast through this. This is a chondroitin sulfate for peripheral adhesion, and then an injectable scaffold, an hydrogel to use with photopolymerization. Or we can use minced autologous cartilage in a scaffold to use their own chondrocyte directly in the OR. And then this is really interesting because you see there are the products used for the second generation SCI, so the scaffold to be used with the cells that now are proposed to be used to enhance the microfracture procedure in a one-step procedure. So the same scaffold, but in a different approach. The most known is the EMIC procedure, the porcine collagen scaffold that is used for in situ chondral induction to guide the regeneration that happens after microfracture. Some results have been recently published. Of course, there are not many patients evaluated. The follow-up is still short. This seems to be promising. And then there is an whole other field. I was telling you before that there is an increasing awareness now on the importance of the subchondral structure. There are many reasons. First of all, the subchondral bone is often involved primarily, like in osteochondritis dissecans, in osteonecrosis, in osteochondral traumas. And also, when we have chondral lesions, but the increased size, the subchondral bone is involved. There is sclerosis, degeneration. So we have to treat it. And so osteochondral scaffold can be used as alternative to OATS, but also to treat large osteochondral articular defect and to reconstruct them. Different cell strategies. I just go through the conclusion. What is the trend is to use in situ regeneration. It's easier, it's cheaper, less regulatory problems that always follow the use of cells. And here what we have in clinical practice. I think everybody knows TrueFit. It's a synthetic scaffold with calcium sulfate and polylactic glycolic fibers. Results are kind of controversial. In ICRS, they have been presented good results. There are also in the literature some doubts regarding the maturation of this scaffold. It seems it requires a long time. So anyway, it's still something controversial that we have to see in the future if we have really confirmed good results with this scaffold. Other scaffold that are just introduced. This is made as a biphasic scaffold made of collagen and calcium phosphate. The results seems promising, but really, really preliminary. These are interesting options because other than the collagen, glycosaminoglycan, and calcium phosphate composition, there is a shape memory that could help to fill the lesion better and to stabilize the defect. And then there is this pilot study going on a osteochondral scaffold that is made of core and hyaluronic acid. The results seem preliminary, but really good. I mean, I saw the results in the animal, and I was surprised. So I'm really waiting for the clinical results. And then there is the scaffold I was talking about. We have more experience, a direct experience regarding this scaffold, so I'm going to spend some more words on this scaffold. And it's a 3-layer scaffold, hydroxyapatite with nanocrystals, nucleated onto type 1 collagen fibers. 3 layers, collagen for the surface, collagen hydroxyapatite 30 and 70% respectively for the bone, and an intermediate layer for replacing the tide mark. After the evaluation in the sheep, we had good results, and in particular, we had same results with or without cells, so we decided to go into clinical practice without. It was easier, and still we have same results with the sheep, so we applied it cell-free. The patients we treated in pilot study were kind of different with respect to the one treated with the chondral scaffold. A little bit more complicated patients, more previous surgeries, more associated surgery, but still we had good results considering the kind of patients we treated and a good recovery stable over time. And also the MRI for the patients who came to the visit at 36 months shows that there is a maturation improvement with also the edema improving over time. What about complex lesions? Good results. In this case, with this scaffold, we have good results also for complex lesions. Still, there is a slower improvement in the elder patients, but still good results. And this is really significant. We compared the results obtained at treated complex lesions with the chondral scaffold and with the osteochondral scaffold, and we observed a significant difference. We had better results in this case treating with the osteochondral scaffold because, as I said, probably in this case, the whole osteochondral unit is diseased, so we have to replace it all. Just a few examples. You see here, there's a multiple lesion, trochlear condyle, and also a little bit, see here, intraoperatively, there is a lesion, also a small lesion on the patella, so many lesions, treated with this osteochondral scaffold. And the results at 6 and 24 months show that there is a maturation of the tissue, there is a filling, an improvement, a differentiation in 2 tissues, bone and cartilage. There is still a little bit of effusion, but patients was playing tennis at this time, so it's still a good result. Another even more difficult case, you see what the disaster after fracture, what we had to treat, and how we treated. We performed an elevation osteotomy, we replaced the entire hemicondyle surface with the scaffold, and we also decided to apply, since it was such an important lesion, and external destructure, dynamic in order to protect this big scaffold, this big implant, but at the same time allow for mobilization. And these are the results over time. Until 36 months follow-up, the patient is great, ROM fully recovered, and also the reconstruction of the articular surface is good. So these are really promising scaffold for complex lesions. But we have to say there is still a huge space for improvement. Improvement that can be done through biomaterial technology improvement, chemical and physical functionalization, or biological augmentation. So now I'm going to pass to the second presentation. I told you I'm going to present together with the presentation of the second generation SCI. And this is the topic of the biological improvement. And this is a really controversial topic. We don't know which cells to use, how many cells to use, when to use them. In the literature, there is something, not a lot. The group of Belgium, Verdonk and Hollander, they showed that actually there is not really support to use PRP plus EMIC for patellofemoral lesions. And then there is our experience. We have a good experience using PRP injections for degenerative lesions. And so we decided to why not trying to increase the results we have with the osteochondral scaffold? At least why not to try to speed the results? And this was really interesting because we went back to the ship and we applied PRP. And we expected to have an improvement, at least if not the end results, to speed the results. But this is what we found. Look, disaster in bone and cartilage. This is really important to me. It has two messages. First of all, PRP is not water. You know, many people say it's just water, it doesn't do anything. Water doesn't do this. So PRP platelets can have a strong effect. And second, this effect can also be dangerous. So it's really important to perform preclinical study before every type of application of PRP. So we can say it's good with injection for inflammation, and then we use it for scaffolds. So it's really important to perform good studies before using in practice. And then there is another big field that is stem cells. What are stem cells? Stem cells are single cells that can replicate itself, but also differentiate into many cell types. We have many types of stem cells. We will focus on adult, and in particular, we will focus on the stromal or mesenchymal stem cells. We know stem cells is many years, more than 30 years, but the concept was increased and made more famous by Kaplan, who defined mesenchymal stem cells as pluripotent progenitor cells capable of differentiating into different cell lineages, bone, cartilage, muscle, etc. And what is interesting that it was so stressed the importance of mesenchymal stem cells to replicate himself. But after many years of research and the new findings, what Kaplan said is that first of all we can find mesenchymal stem cells almost in every tissue. They are probably just around vessels. They can be called pericytes. And they don't have only multipotency properties. They also secrete massive level of bioactive agents, immunomodulatory, trophic, that can have a really important effect that's not direct. So they can just be considered powerful site-regulated drug stores. And he suggested to change the name from mesenchymal stem cells to medicinal signaling cells. So they can change the environment. It's not only a direct action. They can induce other cells to work. Just before passing to the preclinical and clinical studies, we have to make a differentiation when we talk about mesenchymal stem cells. After we harvest cells, we can use in different ways. We can just centrifugate the bone marrow aspirate, but then we obtain a bone marrow concentrate that is not exactly mesenchymal stem cells. We don't know how many there are inside. Or we can expand them. We know more what we have. We have many more mesenchymal stem cells that we can use directly injecting inside the joint or on a scaffold for ex vivo cartilage tissue engineering. These are the different approaches. Important is to remember when we think about these different approaches, we compare them, that these are different products. In fact, if you consider how many mesenchymal stem cells we can find in a bone marrow concentrate, is a really small fraction. This doesn't mean that if there are less stem cells, it doesn't work, because also we have to consider that in the bone marrow aspirate, you don't only use the mesenchymal stem cell, you use the whole environment because there is a cell-cell interaction, there are growth factors, there are other proteins that can influence the environment and the effect of the cells. So it's something really to discover. Just important to remember, they are different products, different things. There are many preclinical studies. I focused on a few examples to show you the different potential uses of mesenchymal stem cells. So what the animal studies show us? For example, Grigolo et al. Showed that you can use mesenchymal stem cells on a scaffold, a hyaluronic acid-based scaffold, and you can even have good results in case of osteoarthritic lesions. Another use is, for example, 1 month after microfracture, an injection of hyaluronan and mesenchymal stem cells. There were no clinical histological difference in the horses, but better results have been observed for tissue firmness, repair quality, at arthroscopic evaluation, and higher aggregate levels. And this was an injection after 1 month. Better results have been obtained even with the marrow concentrate when the cells were injected, placed directly on the microfracture treatment, on the lesion site, without waiting 1 month. In this case, we really had better results for tissue quality, defect field, and integration. So maybe this is another interesting application to improve the results of the available treatment. Here, just we can use mesenchymal stem cell as injection, without other surgical treatment, just pure injection. What they observed, that we can have meniscal regeneration, a less osteoarthritis progression, but they didn't see direct mesenchymal stem cells adhesion to cartilage. So it means that probably the effect was more on the environment of the joint. It was not a direct reconstruction of the cartilage defect. But then there is this study that is really interesting, because it's this way to apply injection. They tried to analyze the effect depending on the dose. And what they found is that with low dose, the effect is at environment level, but with higher dose, they found also the cells at the level of the cartilage lesions. So with more cells, they can go. There is a homing effect. They can find the place where they have to be. So with more cells, cells also go directly in the lesion, and they help to regenerate the lesions. But when we have more cells, there is also a problem of free body and scar tissue formation. So we have also some risk, and we have to be careful when we go increasing the dose in clinical practice. So after this example of uses, let's see what are the studies in the clinical practice. As you can see, studies, there are from 2002, so almost 10 years. But there are not many studies. So if in 10 years there are not many studies, maybe this shows that it is really difficult to work on mesenchymal stem cells. There are many regulatory problems that slow down research in this field. And Wakitani showed already in 2002 that there is a potential for medial unicompartmental osteoarthritis. It was a complex treatment. It was tibial osteotomy, collagen gel, periosteal cover, with or without mesenchymal stem cells. There were similar improvements, but with better arthroscopic histological scores. So it looked promising even 10 years ago. Then he also showed some few examples, a few case series. There was an improvement, not really exciting from a histological MRI point of view. More important is what he showed recently regarding the safety. Evaluating 45 lesions at almost 10 years follow-up, he showed that there is no risk of tumors or infection. This is maybe the most important finding now with these patients evaluated. Other small clinical studies, interesting here is to observe that the results were not excellent in moderate or severe osteoarthritis. And then there are some other proposals. Centeno proposed a really complex protocol using mesenchymal stem cells, bone marrow concentrate, platelet, releasate, dexamethasone. A bit complicated, just one case. So maybe it has to be better demonstrated to be used and extended to the clinical practice. Another interesting application that has been documented is to use mesenchymal stem cells on a platelet-rich fibrin glue scaffold, because platelet-rich fibrin glue can be as a scaffold, but also there are growth factors from the platelet alpha granules that can interact with the mesenchymal stem cells. So this is an interesting finding. Important, even here, results were lower for advanced degeneration. And this is a really interesting study because it was a direct comparison between ACI and bone marrow mesenchymal stem cells at 2 years follow-up. Results were comparable, but in one way even better for mesenchymal stem cells, because in this case we didn't have age-related results, and we had a worsening in the ACI with older patients. So results were good, and another advantage was that we had one less knee surgery, so minimized donor side mobility and reduced costs. So it seems there are advantages for mesenchymal stem cells, but still in this case there are 2 surgeries. What can we do to do 1 surgery? There are 2 options. One option is, as the group of Buda and Giannini showed us to use bone marrow concentrate in the OR. They also add hyaluronic acid membrane and platelet-rich fibrin to cover it, and they treated osteochondral lesions. And at 2 years follow-up, they show really good results, increasing over time, and also satisfactory results also from the MRI point of view. So this seems to be one promising treatment options, one step. And the other option is to use allogenic mesenchymal stem cells. We have to say that in this case, we are kind of lucky because mesenchymal stem cells are immunoprivileged. So it's possible the allogenic use without typing or matching. We can aspirate bone marrow, purificate, expand cells, and obtain a large homogeneous population of cells that can be used, and also long-term stored, 2 years storing, and then used off the shelf. So this is a really interesting approach. And there is one study going on, and it's not finished yet, but the preliminary results look really promising. There is an improvement, dose-dependent effect, less osteoarthritis, bone changing, and the improvement from 6 months to 1 year probably shows that there is not just a symptomatic effect, but really a biological osteoarthritis modification. Let's wait for the final results. This could be really an interesting approach for the future. So summarizing, mesenchymal stem cells have advantages. It's a procedure minimally invasive. The potential is to repair many tissues. There is no immune rejection. And we have different sources. So research can really try to get the best source for this kind of treatment. But there are also some risks. I showed you there is the risk of free bodies and scar tissue formation. The cartilage construct can have inadequate aging because we can have hypertrophic chondrocyte, and this can lead also to the possible differentiation into unwanted tissue like bone. So this is something to consider. And finally, cell amplification is not free from the dangers of bacterial contamination, so we have to remember that too. So concluding, I showed you different regenerative options that look promising, but for sure we need a better knowledge of cartilage pathology, of mechanism of cartilage regeneration, in particular in osteoarthritis. That is a complex biological problem that requires a multidisciplinary biological approach. And the last thing I would like to underline, in particular for this field of research, is that unfortunately it's difficult to say where we are going to be in the future, which treatment will be the best one. Because for this kind of treatment, other than basic and clinical research, there are many other aspects, like regulatory aspects, regulatory limits that changes every time and really slow down the research that can influence the direction of the development of this promising regenerative treatment for cartilage lesions. Thank you.
The question and a final of the. Thank you very much. And now in presentation, the Ulrich notch of the AC with collagen type 1 hydrogels.
Stephen and Pedro, thank you very much. So after this presentation, you might think there's not much to say about